Good morning, everybody. I think previous speakers have beautifully consolidated how you manage a PCR, cortex removal and everything. So today cataract surgery has advanced, which we have never dreamt before, and it has increased the high expectation of the patient also. Never situations are ideal for any cataract surgeon, either the beginner or experienced surgeon. Dr. Arup has consolidated very nicely why PCR happens. It's a recently published IJO article. So one day I happened to go to Dr. Venkatesh's office for something, and he was seeing a 70-year-old male patient with this type of cataract. It's a PXF, hard nucleus with a phacodonosis. I heard him saying the patient, it is a complicated cataract surgery and you need surgery, and my counselor will explain to you. Then patient went out to the counselor. I had a talk with him for 5 minutes. I came out. By the time the patient finished counseling from the counselor's room, he came out within 5 minutes. I was wondering, within 5 minutes, how can she counsel this patient? I was thinking maybe she would have watched Bahubali movie the previous day. She must be thinking Dr. Venkatesh is like Bahubali, he can take that cataract in one go itself. Yes, of course, Venkatesh is a very experienced surgeon, but still complications do occur. He had a nucleus drop, and it is not the nucleus alone, it is the surgeon also into the vitreous. So what to do now? I know experienced surgeons, they will not get panic, they know to manage. As Manavi said, first point for the beginners, don't get panic. Do complete the surgery as much as you can do. Remove the cortex, not going into the vitreous. If the nucleus is up to your visibility, you can remove the nucleus. Good anterior vitrectomy. And if you have a standby retina surgeon, discuss with the retina surgeon. I know all are not lucky like Arup sir, having Meena madam as his wife, but we do have friends, and discuss with the retina surgeon whether they want you to put the IOL or it can be done after the cortex or nucleus removal. Make sure you have ideal IOL power backup. And choice of IOL depends on extent of the capsular damage and availability of IOL and instruments, and expertise of both cataract surgeon and the retina surgeon. And in respect to refractive rehabilitation, placing an IOL as close as possible to the actual location of the capsular bag is paramount importance. It can be in the bag, sulcus or SFIOL. I am not very much in favor of iris fixated IOLs. This is the patient which Venkatesh has operated. You can make out the big PCR and the nucleus is gone in. This is some other patient with a small PCR, but there was epinucleus which went inside. Both situations you can see good vitrectomy. There is no residual cortex, and nucleus or epinucleus is not visible in your eyes, naked eyes. Maybe by the retina surgeons it will be visible. In this case, good in the bag IOL has been placed, and here you can see, because it's a big PCR, IOL is placed in the sulcus. Now you have to suture the wound, hand over to retina surgeon. Of course, Manvi has already showed this video. One thing, before handing over to retina surgeon, clear your visco in the anterior chamber and put sutures so that the globe is intact. So now SFIOL, with a lot of modification, even the anterior segment surgeon or a posterior segment surgeon can easily do a SFIOL. So SFIOL would be ideal in a case of absence of capsular bag. And you remember, in each step, you can always postpone the surgery. Keep the IOL, hand over to retina surgeon. Whenever they want, they can do it. But keep in mind, inflammation and CME, which happens more in the primary setup, which is easier to tackle. But if you are leaving the cortex or nucleus inside, it's going to be a nightmare. Glaucoma is more, and chances of endophthalmitis in resurgeries is very high compared to your primary surgery. So For both the surgeon and patient to be happy, for patient, it's only single stay in the hospital, avoids many visits, which has its own problems like cost involved. They have to travel, some attendant has to come. Already we have promised that they can go back to work in a week, so that's not possible. So fear of no vision, especially in case of one-eyed patients. They'll be either you will leave them aphakic or give aphakic glasses, which has its own problem, even for a shorter duration. Imagine an executive patient with one eye and you're going to give him aphakic glasses. He has to go back to work within a week. What will he do? And doctor's side, your reputation, and you have promised early rehabilitation, and for both the risk of endophthalmitis is less with primary IOL implantation. With this, I had a serious doubt. I went back to the counselor. Why you spent only 5 minutes with the patient? Because you know it is a complicated case. It will have, any surgeon will have complications. What did you do? How you did counseling? She said, Madam, usually I will change only 2 words. For the simple case, I will tell the patient, our surgeon is an expert surgeon. In a complex case, I will tell, our surgeons are expert surgeons. When it comes to counseling, I will say, I will take care of you post-operatively. In a complex case, my friend will take care of you post-operatively. Madam, it's a secret, my friend is a retina counselor. So that's the difference. Thank you.